For most small animal general practitioners, generalized pruritus is the single most frequent clinical presentation encountered in daily exams. These cases arrive in various forms. Some present with severe focal alopecia, others with widespread erythema, and many with weeping moist dermatitis. While the outward symptoms vary, the same microscopic inciting factor can drive each of these distinct clinical pictures. This creates a diagnostic challenge. The patient's own self-trauma, the scratching, chewing, and licking, produces identical secondary lesions regardless of what originally triggered the itch. Attempting to treat these secondary lesions without a systemic rule-out process results in a cycle of clinical failure and chronic recurrence. Pruritus is a clinical sign, not a final diagnosis. Isolating the etiology requires a strict three-tier algorithm: ectoparasites, infections, and allergies. Ectoparasites are the priority rule-out. After clearing parasites, you evaluate the second tier for bacterial and yeast infections. Attempting an allergy workup first leads to misdiagnosis, as underlying triggers remain. Tier 1 establishes a diagnostic baseline using systematic flea combing and skin scrapings. Among the various mites, Sarcoptes scabiei causes some of the most intense and debilitating pruritus seen in veterinary medicine. Burrowing deep into the stratum corneum, superficial and deep scrapings often return false negatives, even in active infestations. The clinician must prioritize clinical distribution. Intense crusting on the ear margins, elbows, and hocks should immediately raise the index of suspicion for sarcoptic mange. If the clinical history and presentation suggest Sarcoptes, a diagnostic treatment trial is indicated, regardless of whether the scrapings confirmed the presence of mites. Completing this trial is clinically indicated before moving to Tier 2. You must definitively rule out mites through a positive treatment response or a full course of therapy. Clinical suspicion of Sarcoptes should override negative scraping data in the ectoparasite protocol. Transitioning to Tier 2 involves evaluating acute moist dermatitis or hotspots as opportunistic colonizations. The mechanical force of the dog chewing and scratching at itself physically fractures the epidermal barrier. This damage creates a warm, compromised microenvironment that encourages the overgrowth of surface bacteria and yeast. Once the barrier is breached, these organisms multiply within the tissue, creating a new source of inflammation and increasing the severity of the itch. To identify the specific colonizer, you must perform skin cytology, utilizing either an impression smear or a tape prep on the active lesion. Eliminating the secondary infection is the only way to isolate and evaluate the primary trigger that initiated the cycle. Localized infections act as complications that obscure the clinical picture. They must be resolved entirely to establish the patient's baseline pruritus. Cytology determines the next step. While bacteria or yeast require therapy, finding only inflammatory cells opens a divergent pathway. This necessitates a dermatophyte test medium culture to rule out ringworm. Alternatively, non-pruritic alopecia without an associated itch requires exiting the algorithm for a skin biopsy. If the patient is not actively scratching, you should stop the pruritus algorithm and pursue a histological diagnosis. Success in Tier 2 depends on distinguishing between infectious overgrowth, fungal disease, and non-pruritic hair loss. Workup for Tier 3 allergies begins only after parasites are controlled and secondary infections are fully resolved. At this stage, clinicians face a diagnostic deadlock. Food-induced atopic dermatitis appears identical to environmentally induced atopy. Many professionals attempt to resolve this by using commercial blood or salivary tests to screen for food sensitivities. These circulating IgE tests have zero scientific validity for diagnosing food allergies in dogs. The only evidence-based method for diagnosing food allergy is a strict 8-week elimination trial using a hydrolyzed protein diet. Hydrolyzed diets utilize proteins that have been broken down into fragments so small they fall below the allergenic Dalton threshold. These tiny fragments evade detection by immune receptors, preventing an inflammatory response. Attempting to shortcut this process with invalid blood tests leads to false results and continued discomfort for the patient. The 8-week timeline is absolute. During this period, the patient must not ingest anything except the prescribed diet and water. Antipruritic medications can be used during the first few weeks of the trial to ensure patient comfort and stop the cycle of self-trauma. However, you must discontinue these medications well before the end of the trial to observe whether the diet alone is controlling the pruritus. Environmental atopy is a diagnosis of exclusion. It is confirmed only when the pruritus continues despite successful parasite control, the resolution of infections, and a failed diet trial. Only at this final point in the algorithm are allergy tests, such as intradermal testing or environmental serology, utilized. These tests do not provide the diagnosis of atopy. Instead, they identify specific allergens for use in allergen-specific immunotherapy. This completed model follows a linear path: rule out ectoparasites, clear secondary infections, and finally distinguish between food and environmental allergies. Skipping the ectoparasite tier risks leaving highly contagious mites to colonize the patient and the household. Bypassing the infection tier allows opportunistic bacterial overgrowth to obscure the underlying cause of the itch. Relying on invalid serology instead of a diet trial often leads to unnecessary dietary restrictions, while the true allergen remains unaddressed. When the sequence is ignored, the diagnostic process reverts to guesswork. Secondary trauma and opportunistic infections frequently overlay the true etiology of canine pruritus. Uncompromising adherence to this algorithmic hierarchy is the only way to achieve long-term clinical resolution rather than endless symptom management.